So the first topic is global burden of viral hepatitis. You are all private practitioners. You must be thinking, why should you know about the burden of disease? आपको इंडिविजुअल पेशेंट ट्रीट करना है, आपको कोई हेपेटाइटिस प्रोग्राम नहीं चलाना है, तो आपको हेपेटाइटिस बर्डन कितने करोड़ लोग हैं, कितने डायग्नोज्ड हैं, कितने ट्रीटेड हैं, ये क्यों सुनना है? Yes, I can see nodding. But it is important because as a country we have committed that by 2030 we will eliminate hepatitis as a public health problem. You know, in India, almost 50% of the people go to private sector. 50% of the people for their illness go to private sector. And unless we involve private sector, it is very difficult to eliminate any disease. So with that in mind, that we want to eliminate as one sector, maybe public sector, maybe private sector. So we should basically know what is the burden of the disease. Because as a part of our sustainable development goal, World has committed that we will end the epidemic of AIDS, tuberculosis, malaria, and combat hepatitis, waterborne disease, and other communicable disease. Combating hepatitis is not only to treat hepatitis, but also to improve the overall health of the being because of preventing its related complications. You know, you must have seen newspaper items, must have known from other conferences that there is a significant decline in number of AIDS deaths. New infections. You must be reading, must be seeing also in your practice that new HIV patients are very few. Similarly, TB, there is a big program for government that by 2025, which was 25, now it has become 27, and it is monitored by the Prime Minister that will end TB. That is by 27. But what is the problem? That public health, viral hepatitis is the only disease where mortality is increasing. Mortality has declined due to HIV, it has declined due to TB, but it is still increasing with and 70% of these deaths happen in 20 countries. 5 are in Southeast Asia, and India has got 11% of global hepatitis burden. So it is very important that basically we address this public health problem of viral hepatitis. And let us see what are the targets. WHO has set some targets that by 2020 we should reduce 30% mortality due to hepatitis and 10% deaths by 2020. We are into 2025, we have not been able to achieve that. By 2030, we should have 90% reduction in new infections and 65% reduction. These may be numbers for you, but it is important that how do we achieve these numbers? So this is very important slide that there are 5 interventions by which we can reduce viral hepatitis. One is 3 doses of hepatitis B vaccine. We have got many pediatricians. I can see in the front seat, Dr. Shalini and others. So hepatitis B vaccination coverage in India is very good. It is more than 80%. But if you see, we want to achieve it to 95% by 2030. But birth dose coverage is very low. So we have gynecologists in IMA, we have got pediatricians. Our birth dose coverage is 74%. Means a person should get a birth dose of hepatitis B vaccine. Anyone who is born to hepatitis B positive mother should get it within 24 hours. That is the target, that is the birth dose. And we are still missing 25% of people. Why it is important? Because once you get the infection during the delivery, the chronicity is 90%. 90% of these children will become chronic carriers. So when they come to you as adult as hepatitis B, it is our fault that we could not give them, their mothers or their babies, hepatitis B birth dose. If you get hepatitis B infection in adulthood, any one of us, the chances of getting a chronic infection is 5% only. But for infant, it is 90% or 95%. So it is very important that this 3 doses of hepatitis B vaccine and birth dose is also given. WHO has also come up with guidelines for prevention of mother-to-child transmission of hepatitis, what is called PMTCT. They say now you should give tenofovir drug to women who are hepatitis B positive from 36 weeks onward. I know some practitioners are following this, but this is still not a part of National Viral Hepatitis Control Program. Why I am emphasizing, unless we bring this implementation and you know about this, we will not be able to achieve. And then is hepatitis B and C testing and treatment. You will be surprised to see in subsequent slide, only 15% of people with hepatitis B know their status, only 3% are getting treatment. The drug is tenofovir, which for a whole year course, 1 year treatment of hepatitis B with tenofovir costs only 2,500 rupees, 1 year. and it is just 3% because we don't know how to manage. And it is very simplified now, as you will see in the subsequent talks. And hepatitis C with 12 weeks of direct acting antivirals, you can cure. 5 years back, hepatitis C treatment was interferon based, 5 to 6 lakhs, multiple courses, 50% cure rate, lot of side effects, fever, pancytopenia. Now these are drugs which are absolutely safe. 12 हफ्ते का कोर्स प्रोग्राम में $40 का मिलता है, 2,500 रुपये, 3,000 रुपये. So there is no excuse that we should not. So that is why this collaboration with IMA is important, that practitioners should know what is the latest in hepatitis B and C treatment. So these are the 3 interventions which I am emphasizing, that which can be done through the general practitioner, through the private sector. More than 50% of people are going to private sector. So what is the global burden of viral hepatitis? We have almost 304 million people living with hepatitis B and C, 254 with B and 50 with C. This is to show you that 254 million people, half of these are basically in group which are 30 to 54 year, but 12% is among children. Again, children get hepatitis B for no fault of theirs. It is just because they could not get that birth dose of hepatitis B when their mother was hepatitis B positive. And hepatitis B testing for pregnant women was not a routine till the program brought it in few years back. I am not sure how much it is done as of now even. Similarly, hepatitis C, we have 50 million people globally, and again 30 to 54 year group, half of them are in that age group. This just shows you these are the 2/3 of the total hepatitis B is in 10 countries in the world. If you focus at India, we have 2.98 million, which is roughly 3 crores with hepatitis B. We have diagnosed only 10%, not even 10%. So it is very important how to suspect and how to prevent. Similarly, hepatitis C, 5.5 crores, 55 million, 11% of global burden. So we have big burden and we need to actually move fast if we have to achieve 2030 targets. The number of new infections has declined significantly, 2.5 million to 2.2 million, but still if you see 6,000 people get infected every day. By the time we finish this CME, 3,000 people would have got infected globally. Similarly, number of deaths basically, as I told you in the beginning, deaths due to AIDS and TB have declined, but viral hepatitis increased from 1.1 million globally to 1.3 million. 83% are due to hepatitis B and 17% due to, and almost 3,500 people die every day of hepatitis. So that is why WHO has sounded an alarm that we really need to increase the testing and treatment coverage. Treatment is simplified, but testing is more important. Whom to test, how to identify those 3.5 crores. So we really need to have a strategy which you need to understand, and Dr. Ekta is here. She will be dwelling more on that. Coming to Indian burden, this is a recent publication which was in 2024, whereby National Family Health Survey was done. I will not take you into details. We have one epidemiologist here, Dr. Chandrakant, but you are all practitioners. So this is the national prevalence of hepatitis B, 0.58, 8.5% of our population is hepatitis B. We have big population, so that is why it is translating to 3 crores. But if you see state-wise, just focus a little bit. 7 states, 8 states have got prevalence, which is more than national average. Bihar, Mizoram, Delhi, Madhya Pradesh, Meghalaya, UP. Large populous states which have got more than national average. So they have more people. So National Program, Viral Hepatitis Control Program has classified these states into high priority states, moderate priority states and low prevalence. Delhi basically comes in a high priority states where prevalence is more than 1%. This is just to tell you that was general population. But if you look into different populations, IDUs, intravenous drug users, female sex workers, MSM, men having sex with them, prisoners, they have got much higher prevalence. You may not be coming into them directly contact with, but this is the data from the program. Similarly, for hepatitis C, our prevalence is low, 0.29%. But if you see certain states like Mizoram, Punjab, Haryana, their prevalence is quite high. You must have heard everything about Udta, Punjab and all that because a lot of drug problem. But you will be surprised, Haryana. See, Haryana has got a prevalence of 0.9%, which is much higher than the national. Why? Unsafe injections. Haryana doesn't have much problem of intravenous drug users who share needles. So it is unsafe injection in the health practice. So we know that IMA has been fighting against quackery and all those things, and you have achieved a lot, but we need to do more. Very important group basically is intravenous drug users. 33% of them are positive, and if you see Mizoram, Meghalaya, Arunachal, 80% of intravenous drug users are positive. You must have come across some of these on Yamuna, Pushta and all other places. And that was traditional thing. Now intravenous drug user is in different groups where we are not able to reach from the program. So you have to illustrate this history, get this history from people who come to you with hepatitis. That will be very important. This is just as I said earlier, global coverage of hepatitis B, only 15% of people know their status, much lower in India. In hepatitis B. Hepatitis C, basically, the diagnosis is 40% and 20% receive treatment. Infection which can be cured in 95% patient in 12 weeks, still it is 20% coverage. So basically, to summarize and move towards the hepatitis free world, basically, we really need to reach these people who are infected. So we really need to know about testing studies, whom to test. We cannot test everyone in the country. So we really need to see which are the focus groups. As I said, we need to reach people who are IDUs, MSM, sex workers, prisoners, and then the context of the people who are already B. It is a policy in ILBS, anyone coming with hepatitis, their whole family is tested for that. And you really need to adopt that also, because the other people in the family may also be infected. And also, very important part, you must be saying differentiated service delivery. You don't need to send people for hepatitis C to ILBS for treatment. There are 11 centers in the Delhi which are treating them free among the National Viral Hepatitis Control Program. But if you get in your practice also, you can treat them. We don't need a specialized care. Just a little bit of training. Hepatitis C is very easy to treat. For B, yes, of course, you will require a little more training, and those who are interested in advanced trainings, ILBS runs separate courses. This is only orientation kind of meeting. So we can have more detailed training. Those who are interested, we regularly do it on hepatitis B, advanced case management. So basically the government has also thinks, and WHO also recommends, and program is also thinking that we need to move away from hepatitis or from gastroenterologist to a general physician or a practitioner for treatment of hepatitis B. So only then we can basically reach out to everyone. Also, we really need to scale up bird dose vaccination. For that, your role is very important. And also, we really need to vaccinate people who are at risk. So that is a brief about the global burden. I hope I have not given you many numbers, but I have tried to give you a summary of this. And with this brief introduction, I would like to move to the next talk. And basically, I would like to request Dr. Ekta Gupta